Yes, yes,
Dr.
madam.
Dr. Sujata
You
is
have
starting.
joined? Yeah.
I think Dr. Sujata
Sujata,
can
we are
start.
starting.
Sujata, ma'am, we are beginning, ma'am.
Yes, start. Yeah, I'm in the office only. You can start.
Okay.
Good evening, ma'am.
Hello, let's
A warm
begin.
welcome to all of you who have gathered here, all the experts and the speakers, and of course our esteemed faculty. This is Dr. Preeti, and I extend a warm welcome to our journal club today. It is on an interesting topics, and let us go ahead with the introduction of our main moderator, that is Dr. Pradnya. Dr. Pradnya Changide is an assistant professor at Sion Medical College, and she is a secretary and manager of Journal of Obstetrics and Gynecology of India. She's an MUHS recognized postgraduate and undergraduate teacher and member of the Youth Council of MOGS, and has published several articles in index journals. So moving on to Dr. Pradnya. Dr. Pradnya.
Yes. Thank you, Dr. Preeti. So I welcome everyone to this FOGSI JOGI ICOG workshop, and we are going to have a lot of good discussions on meta-analysis and two case presentations. Let me introduce our moderator, our master of ceremony for today, Dr. Preeti Lewis. Nilima, can you please show Dr. Preeti's slide? So Dr. Preeti Lewis, she is a professor in Grant Medical College and JJ Hospital, and she is the assistant secretary manager of JOGI. She has various publications to her credit. We have all the office bearers of FOGSI, ICOG, and JOGI with us. A warm welcome to our conveners of today's program, Dr. Sujata Darvi ma'am and Dr. A.G. Radhika ma'am. May I now request Dr. Preeti to introduce both of them.
You are muted.
Dr. Preeti,
you are muted.
Good evening again. It is a great privilege for me to introduce Dr. A.G. Radhika Madam, who is a senior consultant in obstetrics and gynecology at University College of Medical Sciences, GTB, Delhi. She has special interest and expertise in evidence-based healthcare and guideline development, and has held many prestigious positions like National Coordinator for Clinical Research, FOGSI, in the year 2017 to 22, National Corresponding Editor, Journal of OBGY.
Preeti, sorry to interrupt, Preeti. We can keep the introduction short.
Okay,
So
ma'am.
that we are able to.
And a number of awards and publications in your name. Our very own petite and dainty Dr. Sujata Dalvi Madam, who is always bubbling with the enthusiasm. She is our editor-in-chief in JOGI and secretary of MOGS. And a warm welcome to her also, Sujata Madam. Next.
Ma'am, would you like to say a few words, Sujata ma'am and Dr.
Wait, I
Radhika
think
ma'am?
there is some problem with the connections. Yeah.
So, ma'am, should I go ahead with the...
Yeah, please go ahead. Yeah.
Can hear you actually.
I was also facing such problems, but now it's a little
Yes,
better.
I don't know. Somehow it's coming, it's going.
Yeah.
That way.
That way.
Yeah, so Preeti, carry on.
Yeah. The next slide, please. I'm not getting the slide, ma'am.
No, doesn't matter.
Nilima, just introduce Sunita madam, Suvarna madam, Parag sir.
Yeah. So Dr. Sunita Tandulwarkar, she's the head of the Department of OBGY and chief of IVF and Endoscopy Center at Ruby Hall Clinic, Pune, and she's the founder and medical director of Solo Clinic IVF, a center of excellence. And she's our most enthusiastic and a visionary, and therefore she's become now the president of FOGSI 2025. And I am really I am speechless to say that this lady has so much time to do so many things. She started these new concepts of having monthly webinars and many programs across the country, which is very commendable. The next. This is our dashing and most dynamic Dr. Parag Biniwale. He's a senior consultant of obstetrics and gynecology at Pune, and he's the chairperson of Indian College of Obstetrics and Gynecology of 2025, president of Menopause Society Pune in 2018-22,
Thank you, Priti.
and
That's fine.
president of Pune OBGY Society 22-23. The next.
Thank you. Thank you.
Thank you,
So, good evening. I bring greetings from ICOG, and it's indeed a pleasure to connect again on the next episode of FOGSI ICOG JOGI Research Methodology Program and Journal Club. At the outset, let me compliment tremendous efforts put in by Dr. Sujata Dalvi, the editor-in-chief of JOGI, and our governing council member, Dr. A.G. Radhika, who have persistently followed up this particular subject with a lot of passion, and every time we have a program, it's a great learning experience. My appreciations to Pradnya, who's the coordinator. Thank you, Pradnya, for persistently being here and conducting the program so well. Today we are going to have two interesting papers by Dr. Manisha Kumar and Dr. Deepika Gurnani. And of course, we are also looking forward to listening to Dr. Perlin Aman Khan, who's a project scientist at ICMR, Cochrane Affiliate Center. My best wishes for the program. Happy learning to everyone. And I also acknowledge presence of our governing council member, Dr. Shobha Gudi, who's also a renowned teacher from Bangalore. Welcome, Shobha. Preeti, back to you, and let's go ahead with the program.
Yeah. So next is our very own Professor Suvarna Satish Khandilkar, madam. She is the professor and head of obstetrics and gynecology at Bombay Hospital, and she is the Secretary General FOGSI 2025 and president of MOGS at 2024. Madam needs no introduction. She's a rare combination of beauty with brains. Next. There is Dr. Ashok Kumar, Director and Professor of Head. Welcome you, sir. He's of the Department of Obstetrics of Gynecology at Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Ram Manohar Lohia Hospital, New Delhi. And he's the Vice Chairperson 2025. And he's also the editor board member of Indian Journal of Medical Research, Archives of Gynecology and Obstetrics. His interest is in maternal health, medical disorders, and high-risk pregnancy. Next being Dr. Sarita Balirao, madam. She's our most intelligent and well-known consultant of obstetrics and gynecology, and she is the secretary Indian College of Obstetricians and Gynecologists, immediate post chair, AICC RCOG West Zone. Welcome, Dr. Sarita, madam. If I have the permission of Dalvi madam and Radhika madam, can I start with the session one?
Yes,
Can we
please.
start ahead? So the session one is ensuring the quality in clinical research, software demonstration, and our speaker is Dr. Perlin Aman Khan. She has done PhD in biomaterials, Fulbright Fellow, and scientist ICMR. Her current role is Project Scientist 1, Indian Council of Medical Research, systematic reviews of NITI, ICOG, and WHO, evidence synthesis workshops of ICMR Cochrane Affiliate Center, and she's got several publications and chapters in books. I welcome Perlin Aman Khan. Dr. Perlin Aman Khan, please, can you proceed?
So, Perlin, can you share your slides?
Perlin, are you there?
We'll have to check, ma'am.
Yeah, she's logged in.
While Perlin is joining in, I would like to give a brief introduction on the RevMan. RevMan is actually a review manager. So what we have is basically the primary studies and the secondary studies. So secondary studies are the systematic reviews. Systematic reviews is collation of available literature, and then because why are we now talking about the secondary research? The reason is the primary clinical research, probably there is a lot of literature already out there. Number two, there is a problem with funding and the time constraints. So for this reason, there is a lot of focus on the secondary literature, secondary research. So what is secondary research? It is collation of the available evidence in terms of whatever clinical research has been undertaken, which is a primary clinical research. So the advantage is for, if I were to be doing a primary research in my lifetime, what is the maximum number of patients that I can study? So maybe if I have a multi-site, 1 lakh, 2 lakh maximum. But imagine if there are 5 people like me, and if all of us had done that primary clinical research, so 5 into 2, you can easily think how many 10 lakhs of sample size. So that is the biggest advantage of having collating the primary research, and then getting a filtered outcome and the results from those studies for a clinically translatable outcome. So how do we do that? And for that, we have this software which is called as the Review Manager. Review Manager has been hosted by Cochrane Collaboration. So earlier it was the desktop version and you could download it. Now it is available online. And the biggest advantage is people can collaborate online. And the third advantage is that you could enter all the studies, the results, it gives you the risk of bias, develops the forest plot, and ultimately it also kind of gives you the conclusion of whatever data that you had fed in. So the idea of this session today was to show how simple and user friendly is this RevMan, because it can also be used for non-Cochrane systematic review and it is freely accessible. Initially, now Perlin is going to confirm to us because Perlin is from the Cochrane India Center. Now, earlier, this RevMan was freely accessible even to the non-Cochrane author. Later, there was some restriction. Today, she would also be able to highlight to us whether it is available for all people, even the non-Cochrane author. So, is Perlin there?
She has joined, but not responding actually. Yes.
Ma'am, one of the authors has joined. Do you want her? I think Dr. Manisha Kumar.
I think let's do
We
that.
can go ahead
Let's
with
do
that
that.
author.
That's better.
Yeah, please, we
It
go
is
ahead
okay?
with that author.
Yeah. Dr. Manisha Kumar, are you ready to present?
Yes, I'll
Yeah.
present. Yeah.
So we'll introduce the chairpersons. Dr. Preeti.
Audible, please.
So we'll start off with the session number 2, that is presentation of journal articles. I would like to introduce the first expert. It gives me great pleasure to introduce Dr. Dipti Gupta, the Associate Professor at NSCB Medical College, Jabalpur. She's the Secretary of AMPOGS 2024-26, and she's the immediate Secretary of JOGS 2023-24, West Zone Coordinator of FOGSI Quiz Committee, co-convener of FOGSI Quiz Committee. Yeah, and the contributions are quite a lot. Dipti Gupta, Dr. Dipti Gupta, you're most welcome, and please I'll move on to the other, my very own beloved Dr. Vijaya Babri Madam. She's my friend and colleague and associate professor and head of unit at Grand Government Medical College. She's consulted at Kimaya Clinic and she's the ex-DNB senior teacher at Kurla. She's a member of Institutional Ethical Committee at KM as well as in JJ, and a member of Institutional Ethical Committee at KBSR Mumbai, and she's also having a lot of presentations and awards to her merit.
Thank you.
Welcome, Dr. Vijaya Babri, Madam. And now next is Dr. Shweta Kaul Jha. She is currently Director of Nirmaya Care Women's Center, Indore. Her affiliations are Vice President, Indore Obstetrics and Gynecology Specialist Association, Managing Committee Member, ISAR, Joint Librarian, MP, ISAR, and Managing Committee of the member MP IAGE, Executive Member and Convener Infertility Committee AMPOGS, and State Coordinator FOGSI Committee Midlife and Infertility Awards. Most welcome, Dr. Shweta, Madam.
Thank you, Dr.
I'm really very obliged to have you in our midst.
Thank you.
Can one of the experts please introduce this speaker?
Yeah. Shall I take it?
Yeah, sure.
Yeah. So we have the presenter, Dr. Manisha Kumar. Madam is a professor in the Department of OBGY at Lady Harding Medical College, New Delhi.
and her special interest is in fetal medicine and medical genetics. So, and today she is going to present to us on relative prevalence and the outcome of fetal neural tube defect in a developing country. So, over to you, Dr. Manisha.
Thank you so much for the kind words. I would just share my screen and start the session. Is my screen visible?
Yes,
ma'am.
yes,
Yeah.
yes.
So the topic which I've been given was published in 2020, around 5 years ago. And it is relative prevalence and outcome of fetal neural tube defect in a developing country. But I think it is relevant still because only a little bit of things have improved, and that we will see when we progress with the article. So we know that the neural tube defects are the commonest CNS defects, and their incidence in low and middle income countries is 1 to 11 per thousand live births. And when you'll see the data of developed countries, it is 4 to 10,000 live births. So this is the discrepancy. It's so common in our part of the world and not so common in the Western developed countries. And why does it occur? It occurs mainly because of abnormal neurulation process of incomplete closure of neural tube as early as 22 to 32 days post ovulation. So there is failure of closure, and this leads to spina bifida. Failure of closure here leads to anencephaly, and rostral neuropore failure leads to anencephaly. So these are the various sites, and generally the closure doesn't take place in zip fashion, but it takes place at points, and this leads to different effects. So what is the justification? Why we did this study? The study was done because, as already said, neural tube defect is one of the commonest major antenatally detected anomaly. And what we found was the diagnosis was often delayed. And then because at that time, this MTP Act was not amended, so we could only terminate up till 20 weeks. So continuation was the only option left with the couple. And due to lack of data on the outcome, what we saw actually at our level and what was given in the books were quite different. We thought of doing this study. So why there is delay in diagnosis? Delay in diagnosis is mainly because of late booking and because of non-diagnosis due to lack of quality control on ultrasound. Many a times we could see reports with early pregnancy showing a lemon sign, but still it was not reported. So we don't have such audit of ultrasounds, and that was the reason. But in a few cases, like in this case, it is very simple. This is a lemon sign. There's a spina bifida that we are seeing on ultrasound. But in few cases, we even saw and we are being seeing that this is not that apparent. Like in this case, there's no lemon sign and the cerebellum is very well seen. And on 3D, we could see in the sacral region, there was this protuberant meningomycele. So this was the baby which we did repeated scans, and then we zeroed on, okay, this baby has this spinal defect, and then communicated to the couple. So the aim of our study was to evaluate the relative prevalence of different types of fetal neural tube defect and to find out its outcome in terms of survival at birth and after 2 years. So our method, the study design, was a prospective study. So we actually did we took the ethical clearance and all regarding we applied for ICMR, but it was not accepted, but we still continued with this study. So the inclusion criteria was all cases with antenatally detected fetal neural tube defect. We included them. We followed them till delivery and outcome was noted. And then after 2 years, in all those who had delivered 2 years back, we called them telephonically and we took data regarding survival and few more points. So out of total deliveries during 10-year period of 10 lakhs, 1 lakh 2,000, a neural tube defect was there in 4,043. And the cases who were fully followed were 401. More than half of the cases had spina bifida. And anencephaly was seen in around 1/3, that is 35.9%. Encephalocele was seen in around 10%, and anencephaly was seen in 2% of the cases. So these are the different types of anencephaly. We saw anencephaly from say around 11, 12 weeks. This is acrania. There's no proper vault seen, and this brain is being formed, but it will quickly disintegrate until the time the baby delivered. The brain has shriveled. And this is a case of encephalocele with a defect in the cranium with protuberance. So it is a co-closed type of neural tube defect. This is the baby which was delivered by MTB. Now, then there were more than half of the cases has spinal defect. So this is spina bifida occulta. As you see, the skin covering is there. It is a closed type with probably not much problem or morbidity later. There can be a meningomyocele, which has ruptured in this case. And there can be an open defect of spina bifida. This is seen in the thoracic region in this case. This is a case of anencephaly in which there is a fusion or an abnormality in the thoracic and cervical vertebra, and this causes fusion and extension of the head of the baby apart from a spinal abnormality. So coming to the epidemiological profile of cases, most of the patients were young and belonged to the age group of 18 to 27 years. And accordingly, most of them were either nullipara or had one baby. So most of the cases were quite young and no prior history of abnormality or malformations were there. Nearly half of them were diagnosed after 24 weeks of gestation. So if you will see here, the most of them, around 50%, came after 24 weeks of gestation. Now coming to the details of anomaly and the outcome at birth. So as I said, most of the cases were spina bifida, and the age of delivery was quite high because most of them came late and we had to continue with the pregnancy. The male-female ratio of all were almost 1:1, but anencephaly, there were more females to male. Then coming to the outcome, about 1/3 of them opted for termination because they had come early, and stillbirth occurred in around, say, more than 1/3. That is 20% of them almost. And then live birth occurred in around 1/3. So out of total 51%, 15% were live birth. Again, in encephalocele also, very few of them were live birth. Only around 1/3 of them were live born. And that too, mainly those with small encephaloceles. So these are the associated anomalies that we saw. This is a large ventriculomegaly with corpus callosum agenesis and other intracranial defects. This is congenital talipes equinovarus. And this is a case of OEIS complex with omphalocele, ectopia vesicae, imperforate tennis, and spina bifida. And this is a caudal regression syndrome. So these were few cases. We saw some genetic syndromes also, which is associated with neural tube defect. So this is a case of enlarged kidneys with absent liquor and along with an encephalocele, which was there, and a polydactyly. So all three combination, this baby was delivered, MTP was done, and this this baby had polydactyly and all features which were there, the kidneys were enlarged. So this was a autosomal recessive disorder, which has a recurrence risk of 25% compared to a plain neural tube defect, which has recurrence risk of around, say, 4%. So then there was amniotic band disruption sequence, which also presents with encephaly or encephalocele also in many cases. So in this case, there was gastroschisis. As we can see, the gut is all floating and there's cleft palate with lip, and there's a very short cord. We can see the placenta is almost attached, and this mainly happens because liquor is drained early and leading to amniotic bands being formed. So then there was a case of Zuber syndrome, which is a rare syndrome, which also has encephalocele and a molar tooth-like sign of the elongated cerebral peduncles and echogenic kidneys, and it is also a autosomal recessive disorder. This baby is around, say, quite big enough now. So she was at that time around 2-3 years when we had done this study. And this family again had a baby who was normal. So this is a typical molar tooth sign seen on MRI after birth. So coming to the outcome of these cases, so mainly considering of spina bifida, we found that the developmental delay out of say 51%, one third of or less than one third of them had developmental delay. Surgery could be done in more than half of them who survived. Almost whoever survived, we managed to get the surgery done in most of them, and the disability was there in not there in only 13 cases out of total 206 cases. So only 3.2 of the total had no disability at all. So very few cases did not had any disability. Now coming to, we thought about asking them about, as I said, they live after 2 years were only 35. And the reason for surgery was mainly the meningomyosine repair, foot deformity, meningomyosine repair and shunting. So these were the things. And the age of the surgery, when we asked them, they said that none of them actually got surgery done within 1 month. So all of them had surgery done later. And actually, the surgery is supposed to be done as quickly as possible after birth. So it wasn't done, and there were many complications of surgery also that we saw. So just summarizing the outcome, out of all the spina bifida cases, abortion occurred in 32%, stillbirth occurred in 38% of them, and then those who died within 2 years were 12% of them. So we were left with this much, and the physical disability occurred in 12% of them, and only 6% of them had no disability at all. So when I compared the outcome in the developed countries, I referred to this Timor's ultrasonography book, which is a standard, and Timor Trish has done a lot of work on CNS defects in fetus. They have said that around 14% of the children, they die within 5 years of life. And Chiari-2 malformations, of course, the outcome is not that good, and the mortality is 35%. So around 65% of them, they survive even with Chiari-2 malformations. IQ of those who survive is more than 80%. 70% have got IQ more than 80%. Social continence is achieved in 80% of those surviving. Renal failure may occur because of repeated catheterization and renal infections. And they have also mentioned about this MOMS trial or MOMS trial, which has now become a routine in many centers. They said that these babies have better motor function if the treatment or the surgery is done in utero. But it has obstetrical risk in around 10% cases. So what were the limitations of our study? The limitations were that the follow-up was questionnaire based and neurological examination of babies were not done. There was lack of detail regarding folic acid intake, and follow-up was only for 2 years. And though the increase in length of the follow-up could have increased the possibility of confounding variables, and would have told us more about what happened to them till they became adolescent and elder, more to adulthood. And so what is the way forward? The way forward is the high incidence of neural tube defect. We need to reduce it by fortification by folic acid, and half of the cases were diagnosed late. So better quality of antenatal care is required. Only 1/3 of them went for MTP. Now this has been corrected to a large extent. Now we have, say, around only 10 or to 15% of cases who come after 24 weeks. And most of them, we can give the option of termination. And we even have a provision for medical board. And half of them could undergo surgery at our center, and delay in surgery was seen in almost all cases. And there was no disability in only 6% cases. So thank you so much for choosing this study. I think it is very relevant. And I would just end by adding that I did a course from Barcelona. There we had to do a thesis, and so I thought of using artificial intelligence and looking at the lemon sign, whether it recognizes more than us. And it got published recently in this American Journal of Perinatology, and it was a good thing that we could publish this. And maybe more work is needed on this. Thank you so much for patient hearing.
It was a lovely presentation, madam.
Thank you. And it was really an in-depth sonography pictures, and you could take the follow-up of these patients. Very nicely conducted study. Madam, only I want to ask you, those 6% of the patients were no disability in their till 2 years of age. So what kind of a neural tube defect were detected antenatally, so that
Yes.
because when we see as an OBGYN neural tube defect, we feel ki baba, like what will be the outcome. So can you give us like which type we can tell
Yes.
them the prognosis is
Yes.
maybe good, like?
Yes. So most of them were occulta cases, spina bifida occulta, and many of them were those who had sacral meningomyocele. So they had good outcome, and they were relatively better position. So they could, get the treatment done from GB Pant or better hospitals. And in those cases, we could see that they were able to walk, and encephalocele cases also included in them. So these were the main cases with small encephalocele. They were better.
And there was no any
Just wanted to ask
incontinence or
one thing.
anything like
Pardon?
incontinence or anything was not
Yes.
observed.
So in these cases, there was no incontinence, and rest those who had incontinence, we considered them as disability.
Okay, thank you.
I wanted
Congratulations.
to ask, after how many days after birth that they underwent surgery? Of course, I
Yeah.
know it's a pediatric surgery thing, but still, like we were a little inquisitive
Yes. So
to know
when we
when
asked
is
them,
the ideal time for the surgery.
so actually it is to be done as soon as possible. Actually, but in our case, they like in our center, we don't have neurosurgery department. So generally the babies had to go to some other place, and there they had to just be in the queue, and then that took such a long time. So only few of them managed to get it. Like occulta ones, of course, it depends upon their condition, but many of them, they had to actually wait till the time their turn came.
So once it is detected, it is better to deliver these patients where you have surgery facilities so that they don't lack.
Yes,
This,
generally what we do is we ask them to go, but because of all these constraints, they generally they go and they find out and they come back again saying that okay, we are not. I mean, we want to get it done here itself. So this is one constraint that is there, of course.
Yeah, I
Because
think
our
Diti wanted to say something.
Yes,
Yes.
ma'am. Manisha ma'am, congratulations. That's a very elaborate study. And I completely agree. I'm also working in a government medical institute. And sadly, the incidence, the prevalence still seems to be very high. And uh, most of these patients don't report early, like you pointed out. I was just wondering, did you have any patients who were diagnosed with a neural tube defect at the time of delivery itself? Because in our belt, we still see women coming, straight away in labor as referred cases, or in fact, some of them are even completely unbooked without any registration visit also. And if there were any, were they not included or were they included in your study?
So in our this study, we didn't include them because we had when we had thought of including only those in which we did the scan and found something. In a few cases, we had this misdiagnosis also. Like I remember one case in which we had thought of encephalocele was considered to be increased nuchal fold or something, and then when the baby delivered, it was encephalocele, it was a small encephalocele. So we included those, but those, and there are many cases who come and they deliver. Most of them are in a very bad shape, and many of them
Yes.
have multiple anomaly also, especially limb body wall defects. These are but yes, we didn't include them because we had thought of including only those in which we did the ultrasound.
So you mainly wanted to just correlate your own
Yes, yes,
anomalies
yes,
identified
yes,
with the delivery outcomes.
yes,
Okay.
yes, yes.
Okay, thank
I
you.
think
We go
so.
ahead with the next one then.
Thank
Yes,
you so
ma'am.
much.
We definitely need more studies into the determinants of these anomalies.
Yes, yes.
And
We
it was
have
a
done a little bit of study on B12 and zinc, and but
It's
unfortunately,
basically micronutrients and folic acid.
yeah,
Yes.
micronutrient. Yes,
Micronutrients and folic acid. That makes lots of difference.
yes,
your
yes.
Thank you. Thank
gallery
you so
of
much.
those rare anomalies, the photo gallery of your rare anomalies was absolutely beautiful and
Thank you.
commendable, ma'am. You've
Thank
got
you.
a good pictures, wonderful pictures that you have.
Absolutely
Thank
agree.
Chalo,
So
we'll go to the next one.
we move on to the next speaker. Ma'am, can you introduce the next speaker, please? Deepti, ma'am.
Yes, sure. So the next speaker for today's journal presentation is Dr. Deepika Gurnani, who's Center Head and Consultant and Fertility Specialist at Indira IVF Adarsh Nagar, Jaipur. We look forward to seeing you in the conference, ma'am. And ma'am is MBBS MS OBGYN from Umaid Hospital, who did her SRship from Grant Medical College and JJ Group of Hospitals, Mumbai, followed by fellowship in fetal medicine. She has more than 4 years of experience in ART and has been ex-consultant at Medipulse Hospital, Jodhpur, currently working as center head at Indira IVF Adarsh Nagar, Jaipur, achieving phenomenal success rates in her IVF cycles, member of SFM, ISAR, IFS, FOGSI, and who has published article in Journal of CEFOG. Over to you, ma'am, for your paper
Thank you.
presentation.
Thank you so much, ma'am, for the kind introduction. If I may allow, if you allow, I may share the screen. Am I audible,
We
ma'am?
would like to see your face also.
Yes, you're audible, but we can't see your video.
Yeah, we would like to see your face too, Deepika.
Actually, there is some.
Okay, okay.
Hi, ma'am. Hi. Thank you so much. Good afternoon to all the senior ma'ams and gynecologists and the members. Just give me a moment. Yes. Is it visible now?
Yes, it is visible, but you can do it as slide
Slideshow.
Presentation. Yeah.
slide presentation F5.
Yeah. So, very good afternoon, and thank you, Preeti Lewis, ma'am, for giving me the opportunity to present myself and my study here. We have done a study during 2018 to 20, and we have done a study on maternal and perinatal outcome in pregnancy with heart disease, and for the validation of STARPREG2 a risk prediction index, and it was published in Journals of Work. The focus of our study was to evaluate the predictive efficacy of this CARPREG2 index in the pregnancy with the structural heart diseases. And it was done as a retrospective analysis of 66 cases from a tertiary care center in Mumbai. And the outcome assessed were the maternal and perinatal outcomes and validation of the CARPREG2 as a clinical tool. As we know, the global burden of the cardiac disease complicates around 1% of the pregnancies globally. And in India, the tertiary care center reports it to be around 3.1%. It is associated with the significant maternal and fetal risk, including the cardiac failure, stroke, and fetal demise. So there was a need to for a risk prediction score and effective tool which will guide the clinician for the clinical decision and improving the outcomes. So, as objective of our study was one, the index validation to assess the efficacy of CARPREG2 index. And then to identify and correlate the primary and the secondary maternal outcomes with the risk score. The primary outcomes were severe, like the cardiac death and the strokes, and secondary outcomes were the NYHA class worsening. And we studied the correlation of them with the Carprec-2 predictive index. Among the perinatal outcomes, we documented the fetal and the neonatal events such as low birth weight, prematurity, intrauterine growth retardation, and compared them across the Carprec risk strata. And we established the Carprec-2 as a reliable decision support tool for obstetrician handling the pregnancy with cardiac diseases. So it is a risk index. Earlier it was Carpreg 1, and then the Carpreg 2 came into the picture in 2016. So there were 5 general and the 4 lesion specific predictors. Among the general predictors, the one was the prior cardiac events or arrhythmia, which was given 3 points. Then NYHA class 3 or 4, or a presence of cyanosis, given 3 points. So these two were the highest given points among the general cardiac factors. Other two were the high risk valve lesion, given 2 points, and systemic ventricular dysfunction, given 2 points. And if there is no history of prior cardiac intervention, it was given 1 point. Among the lesion specific condition, if there was found to be any presence of mechanical prosthesis, it was given 3 points. In the history of coronary artery disease was given 2 points. And history of high risk aortopathy was given 2 points. In the presence of pulmonary hypertension was given 2 points. The one factor which was added in the Carprec 2 was the care of delivery factor, with the late pregnancy assessment after 20 week was also given 1 point. So this signifies the importance of the antenatal care, especially during early first trimester, in the cases with the significant cardiac diseases. So this score categorized was as a low risk 0 to 1. When the total scoring of the patient came out to be 1, then it was low risk, and moderate risk was given, and when the score was coming out to be 2, and same way 3 was given intermediate risk, 4 and more than 4 were high risk. So study framework, it was a single center retrospective observational study from March 2018 to April 2020, and it included 66 women with the structural heart diseases, and with the complete clinical and echocardiography records were included. And we used a standardized performer to record the demographic, cardiac, obstetric, and perinatal variables. The Carprec 2 score was calculated based on the 10 predictors, and they were grouped into the 3 general, lesion specific, and care of delivery factors. In our study, the demographic profile of the patients were mean age was 27 years, and 91% patients aged between 20 to 35 years. 51.5% were primigravidas and 48.5% were multigravidas. That indicated a balanced parity distribution. As a center is a referral center, so 48.5% cases among all were referred cases, and 27.3% cases had a delayed first antenatal care visit, which was more than 20-week first visit. The functional NYHA status at first visit was class 1 in 66.6%, class 2 in 24.2%, class 3 in 9%, and class 4 in 0%. So the about the distribution of the heart disease in our study population, so it was mainly rheumatic heart diseases, and it was observed in 59.09%, as it is the endemic burden of the heart disease of India. And second most common was the congenital heart disease. It was found in 25.75% of the cases, reflecting improved survival of the congenital cardiac diseases into reproductive age. Other cardiac conditions included peripartum cardiomyopathy among 9%, and LV dysfunction from the secondary to the hypothyroidism, hypertension, and myocarditis in 6%. So RHD remained dominant due to delayed prophylaxis and socioeconomic barriers. The CHD rise shows improved pediatric cardiology. Risk grouping among the study participants. So score 0 to 1 was majority of the low risk cases fell into this group, and observed adverse events were fewer than the predicted. Intermediate score 2 to 3 That included 10.6% of the cases, and score 2 and score 3 12.4%. They showed mixed correlation with the predictive risk. Score 4 showed was found in 10.6 and more than 4 in 30%. Most adverse cardiac outcome happened in this group. So higher carpec 2 score effectively predicted the complication, while the lower score tended to overestimate the risk. So, in our study, when the score was 4 or more, there were high chances of heart failure, about 30% chance of heart failure. Maternal death were observed in the cases of 4 and more than 4. And TIA and stroke was also found in only the cases with the more than 4 score. NYHA worsening was found in all the cases, but as you can see from the graph, it was increasing from 4.2% in 0 to 1 to more than 50 or about 50% in more than 4. And the need of surgery in the pregnancy or postpartum was also high in carpec score 4 and more. So the primary events were cardiac deaths, and they were found in 4.5% cases, and heart failures in 16.6% of the cases, and stroke in 4.5%. All were clustered in high score group. 28.8% had NYHA worsening of more than equals to 2 classes, and 10.6% required the urgent invasive treatment postpartum. Score more than 4 findings among those score of more than 4, 30% had heart failure, 15% had stroke, 10% died, and 15% showed NYHA worsening of more than 2 class, and 20% required surgery. So the chi-square test in p value was 0.9, so that shows the no significant difference between the predicted and observed outcome. So we predicted that the the carpec 2 predict the outcome, estimate the outcome correctly. So that was observed. Among the perinatal outcome, this correlation was not established with the carpec 2 score. So the low birth weight or preterm delivery and other complications did not show a statistical correlation with the carpec 2 score, though WHO class 4 patient showed clustering of poor outcomes. Observed in low birth weight was observed in among 31.7% cases, and it was the most prevalent complication. Preterm delivery accounted for 25.3% of the birth associated with a high carpec 2 score and poor NYHA status. Other complications like oligohydramnios, FGR, and intrauterine fetal death or neonatal death, and total perinatal mortality rate was 4.7%. Obstetric management of the cardiac patient. The vaginal delivery was found to be the most common route, but with a higher incidence of the assisted and the cesarean section. So the most 50% were delivered vaginally, 33.3% normally, and 16.6% with assisted vaginal delivery. Cesarean section was performed in the 34.8% of the cases, where 78% were due to obstetric indication and 21.7% were due to cardiac indication. Assisted delivery included the vacuum and the forceps. The vacuum were used 90.9% of the total assisted deliveries, and 9% used forceps. There were 15.2% pregnancies ended in the abortion, while among them the 60% were due to cardiac contraindication to the pregnancy. There were 3 fatalities in our study, and these were studied. One was due to Eisenmenger syndrome with the VSD, ventricular septal defect, and 2 were due to postpartum cardiomyopathy. The one Eisenmenger patient had the score of 7, and she died postpartum due to polycythemia and Eisenmenger complication, and she had a poor antenatal care received in early pregnancy. Another 2 cases died of postpartum cardiomyopathy, were aged 21 and 31, and both had ejection fraction of 25% and succumbed to death despite the ICU management. So, this emphasizes the need for the early diagnosis, counseling, and multidisciplinary planning in complex cardiac pregnancies, and the need to evaluate the cardia in patient when she's coming to you for a pregnancy. The statistical concordance showed no difference between the observed that we have discussed, and the carpec 2 score more than 4 correctly predict the most severe outcomes of maternal death and heart failure and NYH decline, while the score less than 3 limitations were that it overestimated the risk in the low intermediate group and there were minor discrepancies noted. So overall validity, we confirmed the CARPREC 2 clinical reliability for maternal cardiac and risk stratification. And in other studies also have also found the similar rates of cardiac failure. It was 12.6% in other study. Our study showed 12.6% cases of heart failure, while the original CARPREC itself showed 6.2% incidence of cardiac failure. Stroke and mortality, 4.5% of the stroke and maternal death rates were comparable with the Indian multicentric studies and higher than the global benchmarks. C-sections, incidence of C-section in our study was higher than the CARPREC 2 study, which had 33% of incidence. And CARPREC 2 reliably forecasted the maternal outcomes in the high-risk cardiac pregnancies, but the fetal outcome did not correlate it. And we recommend the routine use of CARPREC 2 assessment tool for all the antenatal cardiac cases. Obviously, there is a multidisciplinary approach that is required to manage such cases, and there is need for early counseling, cardiac optimization before planning the pregnancy, and coordinated delivery planning essential for improved outcome, and need for ICU management. Thank you so much. And this was the comparison with the other studies that showed the higher cesarean rates and instrumental deliveries are also higher. And overall, we found it to be a good predictive score.
Thank you, Dr. Deepika, for the
Thank you
lovely
so much, ma'am.
presentation. Any questions from the experts?
So, Dr. Deepika, you said you have offered MTP for few patients. So, what was the route you opt for the MTP? Like it was in medical or surgical?
Before 7 to 8 weeks, it was medical, and after 8 weeks, it was surgical.
So again, depending upon the CARPEC, that scoring, whether you have given them on a OPD basis or you admit being these are the high risk patients,
No,
admit
ma'am,
and
we
then
have admitted. We have admitted them. We have admitted all of them because anyway, if she bleeds in a cardiac condition, then she's in more at risk for cardiac decompromisation. So we
yeah.
have admitted all those.
Yeah. And in your study, I think I have seen the vacuum was higher than the forceps, the 90% versus 9%.
Yes, ma'am.
Yeah, okay. But usually we put forceps rather than the vacuum in the cardiac conditions, right?
Yes, ma'am, because the forceps expedite the delivery and a vacuum take a little longer.
Yeah, and you need
But
the maternal force also for that.
yes. But ma'am, the expertise of the obstetrician working like
Yes.
mostly we have the residents working overnight, so the expertise is also important to apply the forceps. And with the vacuum, I guess it comes with a little less graph of the learning of vacuum
Okay.
delivery.
Yeah.
Any more questions?
I'm seeing the chat box also. I don't think there were any questions in the chat box. So it was a nice study and thoroughly conducted. So really we can refer this scoring system to categorize our patients.
Thank you so much, ma'am. Thank you so much.
Thank you, Dr. Deepika.
Thank you.
Can I ask Dr. Perlin, madam, to present? Is she ready now?
Hi, hello. Very good evening to all of you. Thank you so much for cooperating with me. The senior DDG ICMR had requested my presence actually, so I could not avoid it. I'll start sharing my screen and I hope it is visible to all of you. Just give me a minute. It's a wonderful series of lectures that is going on here, and I'd like to bring something different to the table, which is systematic reviews on the primary evidence that you are looking in from your eyes. So, is my screen visible to all of you?
Yes, it is. Yes, it is.
Yes. So,
Can you do F5, please, like slideshow? That will be
yeah,
better.
here I go. So I'll just give a very brief introduction to somebody who's very new to Cochrane. So Cochrane is established evidence-based non-profitable organization. It is a UK-based organization, and Cochrane reviews are very famous for giving their WHO guidelines and recommendations. And so we are at ICMR, a Cochrane affiliate center in India. There are 9, and we are one of them. And here I'm going to introduce you to RevMan, which is a Cochrane software which allows them to carry all the systematic reviews and conduct the systematic reviews in them. And this software allows you to do multiple things, which I'll tell you right now in detail. And this will be followed by a demonstration. So just to begin with, in the basic of the pyramid, it, as you know, comes the in vitro animal handling and basic primary research. But those research are only meaningful when they get transformed into clinical applications or they become guideline. That's where the secondary research has come, which is when the randomized controlled trials actually give you an evidence, but those evidence are of what quality that you assess from a systematic review. And these different randomized control RCTs that are done all around the world based on the similar PICO that you take. PICO stands for population, intervention, comparison, and outcome. So you see RCTs on a similar PICOs which are done, and then you combine them to see what was the outcome, what was the result all in all these different studies, to see if they are giving you a combined good outcome, or how do you assess the result. So what we do is the quantitative values, we combine them and we call them meta-analysis, which is only done when there are more than 2 studies. So a systematic review can be conducted without meta-analysis, definitely, but a meta-analysis is an integral part of a systematic review. A meta-analysis cannot be conducted alone. So all the systematic reviews need not have meta-analysis. Now, what the RevMan, the software, can do for you is that it can import citation from the studies. You can define the PICOs, like I told you. You set up the eligibility criteria. So when you start a systematic review or when you do a clinical trial RCTs, you have inclusion and exclusion criteria. So apart from that, you have outcomes to measure what are you comparing it with and the population that you're interested in. So that is basically the definition of PICO, and you set up that criteria for analysis. Then you import the study data, and then you manually enter these numerical values and the descriptive qualitative part of the systematic review and generate a forest plot for the meta-analysis, and then you write the review and submit it. Uh, Once the review is submitted, this is the cycle that generally happens, and the Cochrane reviews are very effective. The time taken duration for them is somewhat criticized because it is over a year. That is because when you have multiple studies, the reviewers have to dig deep into each study to see if everything was done correctly or not. So that does take a lot of time in comparison to the other primary research studies, where the reviewers don't actually see your data because it's a primary study data. They have a leap of faith on you, on the authors, and they believe that what they've submitted is correct, the numerical values, and they go forward. But that doesn't happen in the Cochrane reviews. So you start with a new review. I'll try to see if you can see my laser here. Yeah. So you start a new review, it gets assigned, and then monitor and support of review takes place from Cochrane. It gets evaluated, and then uh, once it is evaluated, it gets published. Once it is published, you then need to update it. So Cochrane reviews do get updated over the time. That's why they are live Cochrane reviews now. So work on reviews in RevMan that you can do is you can set up meta-analysis in review, you can import studies, like I said, you can write the review article and export content from RevMan as well. Uh, this is the QR from to RevMan. You can scan it, you can Google it, you can use it. It is not a free software, but you do get a free 1 month trial though. And to get it, there are 2 ways to get it. One is subscription based. The other one is if you submit a title, which is on their thematic groups, which is important for them at the moment. They will take that into priority, and then they will accept your title, and then you have to submit the protocol. And once the protocol, that in-depth protocol, gets approved, then you go ahead with the review, and that is when your RevMan, you get a free access of RevMan if you are an Cochrane author. So then you create a review, you can register using RevMan, you create a review, and you can add authors and support rules. You can do manual analysis, like I said, for simple analysis, small set data already structured in an expected format. It does not allow you to change the data into different units though, but it does provide you a calculator, which I'll show you in some time. So automatic analysis, what it can does, if you have data, if you're doing screening in COVID, so for screening we have a different software. So just to give a brief idea, after we submit a protocol, we go for searching. So we find in the uh, repositories like Sinhal, Embase, and other Scopus, Elsevier, all these repositories, we try to put your PICO there, and you try to get as many articles as possible. So when you put a PICO, your population on your intervention, your outcomes, you may get multiple items. There are multiple hits. So those hits can be in thousands, but you cannot do meta-analysis for 1,000 articles. So you screen them. Maybe they will not be of your interest. So the screening is done in a different software, which is Covidence. And there are free softwares like Ryan, Kedima, uh, Distiller SR. Distiller SR is paid. So multiple softwares are there, which you use to do the screening. Then you do the screening based on just the title abstract, and then you reduce the number, and then you again do the full text to see, does this study uh, fit into my criteria, and then you take into the consideration, you do the full text, and then you start putting it into the Revman. So before going to Revman, there are multiple steps that you need to accomplish. Revman, however, the software of Cochrane allows you to automatically combine the arms. If you have multiple arms, then it allows you to do a subgrouping, and then you can reuse the data for several analysis like sensitivity analysis. And for most analysis, but especially valued for it is the large set data that it automatically does, and features described on the previous slide, and just similar things. Now, there are different portfolios that you can manage in the Revman, and it will allow you to have a validation screen which lets you check how many errors are there in your manuscript. So let me just open the live demonstration. This is the page how it will look, and let's go to it. So if I log out from here, this is how the front page of login of Cochrane will look like. And then when you log in, it will show you my reviews. So you will see 3 different types of reviews, and then you can start your practice review here. But then the practice review will have an expiry date alongside it. So I will show you my review, which is on probiotics for prevention or treatment of hypobilirubin anemia for late and preterm neonates. And I'll show you how to enter the data in here. So here validation is coming 0. That is because all the content is already filled and the errors have been sorted. So when you start here, the studies will prompt. So you have to start included studies, and this is how you enter the data. You will add a study here. I think because this is submitted, so I am not able to make changes. I will go to another one, to the create one, and I'll add study, included studies, and I will add a study. So, and the risk of bias also gets done here. So I'll do demo year 2025, and I will write. So you need to have your full text in a copy or in a soft copy opened when you're filling this. Then you will have to manually enter the reference. So you will go here and you will enter the reference, that is it a journal, is it a conference proceeding, is it a computer program, is it a clinical trial which has data published but the manuscript is not available, which you contacted the authors and took, is it a Cochrane review? And so you'll select that, you will fill da 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 da, and then you will go back to the study. Here it comes. So you will start filling the characteristics. So the characteristics will be methods. Is it an RCT? Then you will see the participants. So in my case, if the PICO was neonates late term and preterm, so I will check the I'll check my paper, the study, and I'll see what was the type of participants. It was late, preterm. So the participant list, I'll write the inclusion criteria was more than 38 weeks old. Basically, you'll define. So what intervention did they use? They used a probiotic, say Derolag, and what was the dosage that was used, and what was the frequency, and then you will write the outcomes. What outcomes with respect to the protocol that was initially submitted of my interest are reported. So our protocol had duration of hospitalization and phototherapy. So you'll enter this. If there are any notes, you add it, and then you go to the next one. Covariants are not there. There's no study arm. There's only placebo and intervention, and then the result data. You will go to the risk of bias. So here in the risk of bias, you will say if the random allocation sequence in the clinical trial is if it's defined, then you will put it low, and then you will quote why did you put it low. So you have to quote the manuscript. What it stated. So it may state that the random value sequence generation was done using a computer assisted software or web based. So you'll go on forth, and then the allocation concealment, like that you will rate it low risk. Whatever judgment you give, you need to justify it. So if you give unclear or high risk, you will give that judgment, and so it will come up. This will come when you do the meta analysis. Here in the analysis part, say I'm going to start with a new analysis. I'll add that as a demo analysis. I'm clicking manual here, okay? So in manual, I will go with continuous. So continuous we use when there is a measurement which is more than binary. So if you're measuring blood pressure, if you're measuring diabetes, if you are measuring serum bilirubin level, it will be in continuous mode. But if you're seeing rate of mortality of death or events, that will be in dichotomous. If it is 0 or 1, how many died, so the number of those people will come. If it is not a unit value, it will come into the dichotomous. So experimental group and this, and then you will start adding the data. So you will add the data row and all the studies, the references that you entered. So I'm taking from my demo, I will add it here, and this demo line will come. So I will see in the experimental group, if this analysis is for duration of hospitalization, say it was 3 days, and then the SD was plus minus 1, and the total number of participants N was 50 in the intervention group, and so on. For control, maybe it took more time, so I will put mean is equal to 5 days plus minus 1, and then total number of patient that was there in this group was 50 again. Like this, I will have to enter individual values for one particular outcome and keep adding this. For example, if it's done here, this will be the forest plot that you will see. So for other analysis, this is a demo one which says caffeine for daytime drowsiness. So it has headaches as an outcome, and people who had headaches, so it will be a dichotomous because you will either have headache or no. The severity of it cannot be measured as of now. So we'll put it as events, and you will see a forest plot with effect favoring the decaf caffeine. So this is my very brief total overview because it is a very in-depth uh, topic. We cannot do it in 20 minutes. So if you're trying to do how to fill data and doing meta-analysis, a very brief intro is this. But if you have more doubts, you can definitely contact the ICMR Performance Rate Center, and we can have a workshop, a one-day workshop, a two-day series of workshop where we actually demonstrate this and let you do a hands-on. But for FOGSI, just a research journal presentation, I think this might be too much or too fast for you. So I'll try to.
No, I would say, Berlin, I think that was a great presentation, but I would also want to tell the audience here that Cochrane itself has tutorials available. They are self-paced. You could go to the Cochrane website and
Yes.
look for trainings. And, it's very easy, simple,
Hmm.
but you need to reiterate many times. So
Exactly.
you
You
get
have to be
familiar with it,
responsible for it.
and
Yeah.
so it will it's very interesting, so, and quite addictive. So I would encourage everybody to
Yeah.
have a feel of it.
The good thing about Cochrane is that all their data is available free on their website. So if you are eager to learn, you can join in their webinars, which will give you reminders. And as long as you persevere to do it, they will have something to help you out. So there are these Cochrane webinars and Cochrane demonstration classes that you can take up. And you can just Google Cochrane. This is the logo of Cochrane, and you will see this website. And we also do, when I said searches for repository, we also look into the Cochrane library, which is a very well-known, vast database for this. I'll just share my screen to show you the last final look of the website, and that's a wrap from my side.
So any questions? Most welcome to ask questions or clarifications, comments, or discussion points. I think this is just a teaser.
Yeah.
So it's a quiet front from the audience today. So people are welcome to ask questions, but yes, this is just a sensitization. So please do, have a look at the Cochrane website. And today, the point is, please don't think only of the primary research. Consider doing the secondary research, which is the need of the day for our country, because it is secondary research which is going to help us to develop guidelines. Guidelines develop out of the best research evidence, and as Pauline had just shown in the second slide, in that pyramid of evidence, systematic reviews were holding the topmost place. So it is from there that the guidelines come. So it is high time that we also start undertaking secondary research, and RevMan is a good tool for us to, build the visual results of our meta-analysis. So thank you very much, Pauline.
Thank you, ma'am.
Thank you
through
for that
Cochrane,
enlightening presentation, Dr. Perlin. Any
there is a
questions?
question here. Yeah. Through Cochrane, can we publish the research work? Yes, of course. We are not able to see your name. It says OC. Cochrane, it's basically for systematic reviews. So your protocol has to be registered. You undertake the systematic review, and then you can publish it. So Vikaya Durga, So Dr. Vikaya. So that is the way it is. So it's basically for systematic reviews. So primary research is generally not published there. So thank you everybody. Thank you very much for your patient hearing.
Maybe I just saw her. Pradnya can give vote of thanks, Pradnya.
Yes, ma'am.
Yes,
Yeah.
ma'am. Thank you.
So we had an excellent session like every time. I think the audience in number is less, but they are very deeply interested in research methodology. So with the blessings of our president, FOGSI, Dr. Sunita Tandulwadkar, chairperson ICOG, Dr. Parag Biniwale, chairperson-elect Dr. Sheila Mane, Dr. Ashok Kumar, vice chairperson ICOG, Dr. Suvarna Khadekar, Secretary General FOGSI, and both are dynamic conveners, Dr. Sujata Darvi ma'am, Dr. A.G. Radhika ma'am, our master of ceremony, Dr. Preeti Lewis, and Nilima from ICOG, who takes lots of efforts in organizing all these research methodology programs. And obviously, both the speakers, the experts for this session, and all the audience who are attending, I would like to extend a vote of thanks. And we'll be having the similar program every second Tuesday of the month. So we hope to have you again. And some people want the recording. So Nilima, I think we'll be sending the recording.
Yes, madam. Recording will be uploaded on ICOG website, madam.
So you can check the ICOG website for the recording.
Yeah.
So thank you, everyone. And both the speakers spoke very well. And Dr. Berlin, we really want to have a full day session on Cochrane. It was really very informative. Thank you so much.
And thanks to you, Pradnya, always
Thank
holding fort.
Yes.
Thank you.
Thank you,
Thanks to
Dr.
all the
And next
speakers.
month she is going to
Preeti
select
and
the
everyone.
topics. Okay, Pradnya, you are going to select 2 topics.
Yes, ma'am, I'll do that. Yeah. Thank you, ma'am.
Okay.
Yeah.
Okay,
Thank you so much.
good evening, everybody.
Bye.
Thank
Bye.
you.
Good day.
Bye.
Yeah.
Thank you. Thank you.
Bye, everyone.
Bye.
Thank you. Bye.
Bye. Thanks.
She has stopped the recording.